Absolutely delighted to introduce Uchu Meade, one of the experts in pouch care at St Mark's Hospital. Uchu's head of pharmacy at St Mark's, privileged position, and she's a fabulous pharmacist who supports the charity every year. And we're delighted to have you back, Uchu, talking about the pharmacy of J-pouch and how to use drugs to control your symptoms. Over to you.
Again, thank you so much for first of all the kind introduction and for the invitation. It's honestly one of my favorite things to do patient education and training. So when you're invited to take part, it's very special. So thank you very much. My internet connection is a little bit weak because I'm having to use the back room where nobody lurks in my house normally. So in order to boost my connection, I've had to keep my camera off. So yeah, you don't have to see my face, but you can hear my voice. So what I'll do is I will try to share my slides and just make sure that they're all moving correctly. So, okay. So, thank you so much. The talk I'm going to give today is taking the tablet, the best guides for drugs when and how to take them. I said Uchu Meade, consultant pharmacist at St Mark's Hospital. I'm sorry I forgot to update that date. This presentation was updated this month in preparation. So the aims of the session, I'm going to go through. So when we as healthcare professionals think about medications, especially with patients with altered bowel anatomy or physiology, we take into consideration pharmacokinetics. And it's something that a few years ago I started working with my patients to teach them and educate them about. Why did I start to do that? It was just to make sure that they had those tools and those skills. So when they were dealing with professionals outside of St. Mark's who didn't maybe understand the importance, that they had some baseline understanding as well. And the feedback I got was very positive. So I've continued that when I do patient education. So I'll explain what it is, why it's important for patients with pouches, and why do we use different routes to administer drugs, just so you can understand that. I'm going to go through a little bit about different classifications of medications. So this will really help you when you're getting medications from the hospital, the GP, or you're buying it in the community pharmacists. We'll look a little bit about prescription-only medications and the costs and how to try to minimize these costs if you are paying. Go over some over-the-counter medications, and hopefully I'll try to give you some hints and tips of things to avoid and with your pouch. We'll go over a little bit about medication in pregnancy and breastfeeding as well, and just where to find a little bit more information and support if you need it. So we'll start with pharmacokinetics. So what is pharmacokinetics? It's the movement of medications within the body. So all medications are designed to Can you still hear me?
We can.
Yeah. Sorry, my computer went dark there. I hope it didn't affect the screen. So all medications are designed to target a certain cell or receptor in the body. But in order for the drug to elicit a pharmaceutical response, sufficient amounts of the active form of that medication must reach the site of action before the pharmaceutical response is given or seen. And some of the drugs that we give, especially to our patients with pouches, target receptors actually within the GI tract itself. So there's four main key elements to pharmacokinetics. It's your drug absorption, your distribution. So when the drug's absorbed into the body, the way that the drug is distributed around the body. Metabolism, how that drug is broken down and removed from the body, is elimination. So that's the final stage. Metabolism, drug broken down, and elimination when the drug is removed. But for us, in patients with pouches, the most important thing that we need to consider is the absorption, because the vast majority of medication administered in the oral form. So these are tablets, capsules, and or liquids. So it's really that absorption that's the most important for our patient group and for us, for the team working at St. Mark's. And the vast majority of absorption happens from the GI tract. But then again, we've just got to be cautious with patients who have their altered physiology and anatomy of the GI tract, because you might have a reduced surface area. And not only reduced surface area, some drugs are designed to absorb in certain areas of the bowel. So if that certain area of the bowel has been removed or altered in any way, shape, or form, you might lose that absorptive ability from because you don't have that area of the bowel. We also need to take into consideration the transit time. So you might have some patients who have an increased or reduced transit time with the stomach or the small bowel. And we also need to think about the quality of the remaining bowel that a patient has. So you could have one patient who has 100 centimeters of bowel and a pouch, and they're able to absorb the right amounts of nutrients and drugs to maintain health for them, or what is healthy for them. And then you might have somebody who has the same 100 centimeters to a pouch, but has disease in that 100 centimeters, so the quality of the bowel isn't as good as patient A. So it's just all things to consider, and things that your healthcare professionals will take into consideration when prescribing for you. Another concept I wanted to talk to you about is oral bioavailability. So oral bioavailability is the amount of medication that reaches the systemic circulation after a drug has been administered via the oral route. And this, a lot of the all of the studies that are done when medications are in their first early clinical trials phases are based on healthy individuals. So not on patients with altered bowel physiology or anatomy. So pharmacokinetics, why is it important for pouch patients? So again, it's back to that absorption. We need to make sure that any medication we're giving, the amount of medication that reaches the systemic circulation is going to elicit that pharmaceutical response. We need to think about the bioavailability. So how much of that drug is going to actually reach the systemic circulation, so your bloodstream, and just to make sure that we are having those sufficient amounts reaching. So just for caution, and I know in the past when I've given this talk to patient groups, some people have come and spoken to me afterwards and said that they've been prescribed medications that are deemed to be modified release preparations. And these preparations are designed to either have a slower release, so to release slowly as it transits through the length of your bowel. And sometimes these slow release preparations are not appropriate for patients with pouches. And then also as well, there's some drugs that are formulated and designed to release in the colon. So I always say that it's really important to understand your GI anatomy from your team here in St. Mark's or your centre that's working with you and supporting you. And if anybody is going to prescribe you a medication, whether it be in another hospital, another team, in your GP practice, or you're getting advice from a community pharmacy, just explain to them your anatomy as you understand it, so it can help them form a good opinion and help them care for you in the best way that they possibly can. But a lot more research is needed in this area, which, St. Mark's is very keen on its research, and some is going to be undertaken there. So yes, this is basically me saying the same thing. So so I'll just read it out again to emphasize the point. Your healthcare professionals will monitor your clinical outcomes to all prescribed medications and alter as needed. So because we aren't able to know sometimes how a drug will work, sometimes your team or whoever is prescribing for you may try the drug, but then monitor the pharmaceutical response that they're looking for. So for instance, if they want to prescribe, or if you're being prescribed a drug to lower your blood pressure, they'll monitor your blood pressure. There are also some drugs that that we can monitor what we call drug levels in your bloodstream. So if you're given a drug and we're not 100% sure of whether you'll absorb or not, we can give you that drug and then take samples of your blood and monitor to see if that drug level in your blood or your systemic circulation is within what we call a therapeutic range. And when a drug is in therapeutic range, that's when we see the pharmaceutical response that we're desiring. Sometimes patients with altered GI anatomies or physiologies or with pouches might be prescribed higher doses than patients with normal bowels or with normal GI anatomies. They might be prescribed for a shorter or longer durations, and we might have to alter routes. But all of this will be monitored and talked through with your healthcare professionals as they prescribe. So I just wanted to show you this diagram here, just to hopefully help explain what I've been talking about a little bit, just give a summary. So if you were to give medications via the oral or rectal route, it'll first need to go into the gut and then be absorbed and then enter the plasma. And from the plasma, it will go to its sites it'll be distributed around the body to elicit its pharmaceutical response. And then it will either go to the kidneys to be metabolized, and then to the liver to be metabolized, and the kidneys to be excreted, or it can be excreted directly from the bowel. So this is oral or rectal routes. You do need your gut, whereas if your bowel is not able to absorb the drugs because of the site of absorption, the quality, you don't have the right surface area, or that section of your bowel is missing, we do have in our toolbox other routes to administration. So you might find some of you might have heard of the term polypharmacy, which is when patients are prescribed multiple drugs for different diseases or different drugs for the same diseases. But we also now are starting to think about for our patients in multi-route or polyroute prescribing, where some patients might have some things orally because yes, it can absorb, but then they might have things intravenously or intramuscularly, where you're bypassing the bowel directly and going directly to the plasma, and that's just to help maintain those plasma levels and give you that pharmaceutical response. I hope that all makes sense. So now I'm going to move to classifications of medications. I'm going to start with drugs called prescription-only medications. So these can only be prescribed by a healthcare professional with the relevant qualifications. So at St. Mark's, we have our doctors who can prescribe. We have pharmacy prescribers, we have nurse prescribers, and we also have dietitian prescribers as well. So doctors, when they qualify, they can all prescribe, but nurses, pharmacists, dietitians will have to do extra qualifications. So please don't be worried if you are being, if a nurse, pharmacist, or a dietitian asked to prescribe for you. It's all very heavily governed in the trust, and excuse me, it's all very safe within St. Mark's. And also outside of St. Mark's as well, you'll find the same cohort of professionals who will prescribe prescription-only medication for you. So I just wanted to say that to you so you don't get alarmed or worried if you find a different healthcare professional prescribing medications for you. So the Paramide Encoding are prescription-only medications. So I just wanted to talk about how they work a little bit here. So some of you might have used the Paramide Encoding to help reduce diarrhea. They act on the receptors in your gut. And I know I said earlier on in the talk that there's some target receptors that are in the gut, while the Paramide Encoding have their target receptors within the gut. They work to reduce bowel motions or motility, and this allows more contact time, so increases the absorption, resulting in reduced bowel frequency and quantity of bowel or diarrhea or stool. Cephaloperamide encoding. Cephaloperamide, we do go up to about 16 milligrams 4 times a day. It's more favorable than starting some, so we'd always start with loperamide, and if a patient needs additional support, we'll add in the codeine, and it's more favorable because it's non-sedating. Also as well, there are, maybe I'll come back onto that in a moment. There is, so for loperamide, there's very little absorption from the GI tract, and that's why we know that the main mode of action or the main target receptor for loperamide is in the bowel. It's available in capsules, so some of you on the call might have taken it in capsule form. It's available in tablets, and it used to be available in liquids. I left this in here and crossed it off because this year the liquid preparation was discontinued. So we no longer have access to that. But in all honesty, for our patients with pouches, the liquids weren't great, so we didn't tend to prescribe them that much. And we also have the melts, which dissolve in your mouth. So with the codeine, the maximum doses are 30 to 60 milligrams 4 times a day. We try not to exceed the maximum dosing with codeine because it's not recommended. It's also a pain relief, and in combination with paracetamol in very low doses, so 8 milligrams, it can be sold in pharmacies. One thing about codeine that we do know is that it can cause dependence. So where possible, this is why we start at the second line and we monitor it closely for our patients as well. And as I said earlier on, we start with loperamide and then we move to codeine, but using the combination for a lot of patients, that they find that a lot more better to relieve their symptoms of diarrhea. So it's like an orchestra. If you have one instrument playing, you get a nice sound, and if you get two, you start to build up that sound. So it's the same as that. You're adding a component in that has a slightly different way of acting, so giving you a better outcome. So how to take this? Ideally for codeine and loperamide, take 30 minutes to 1 hour before meals. So why do we do this? It's to allow the drug to start working before you eat and drink. So the bowel should the drug should hopefully start slowing down the bowel before you eating your drink. So by the time the food and the drink enter your bowel, it's already slower. So it allows more time for the food and the drink to be absorbed. Side effects, we've got to balance this with the higher doses. So the main, with a lot of medication, the higher your dosing is, the more likely you are to experience side effects. So for loperamide, it's abdominal pain, bloating, nausea, and fluctuants. And for codeine, it's drowsiness, headaches, low blood pressure, nausea, and vomiting. So if you are experiencing any of these with loperamide and codeine, next time you see whoever's prescribing this for you, if you let them know, hopefully they'll be able to help you find that balance between a dose that's effective for you, but one that's not giving you side effects. So what you might see on a lot of loperamide labels is only give 8 tablets or capsules in 24-hour label. But please ignore this. This is not for you. We do know it's safe to go up to 16 milligrams 4 times a day. Other drugs that you might come into contact with or see on a regular basis prescribed because of your altered GI anatomy and physiology is vitamin B12. So this tends to be absorbed from your terminal ileum. So we might need to give this intramuscularly as an injection. It tends to be once you're past your initial loading doses, it's 1 milligram every 1 to 3 months, and this can be from the hospital or the GP practice. If you have low vitamin B12, you might have been diagnosed with anemia, and the doctors would have taken your levels, and if they were low, they can top you up. But it's a continuous cycle because you do some patients with pouches will have that reduction of absorption from the end of their ileum. Vitamin D is absorbed from the jejunum, and we do see patients with low vitamin D levels, again, picked up from blood results or picked up from patients presenting with symptoms, and we're able to link it back to patients who have low vitamin D. We can give oral and monitor vitamin D levels to see if they're coming up, either a daily dose of 800 to 1,000 units once a day, or a weekly dose of 20 to 25,000 units. But again, as I've said earlier on, the oral route might not be appropriate for patients with pouches. So we then need to think about how else can we give it. So going back to the diagram where you have lots of the different routes, we can think about looking at the intramuscular injection route. So we give another form of vitamin D, which is ergocalciferol, and that's 3,000 units every 1 to 3 months. And again, that's from the GP's surgery or the hospital. We do have the ability with these two to monitor levels and to make sure that your levels are rising sufficiently. So Pouchitis, the first line in our trust is ciprofloxacin and metronidazole for 2 weeks, and then tinidazole and rifaximin for 4 weeks is our second line. So how to take, these are antibiotics, and you might have heard a lot of publicity about taking antibiotics safely and antimicrobial stewardship. So we must take them regularly, take them at the same time each day. Ensure the timing fits around with your lifestyle. So for instance, if you know you're going to struggle to take them at lunchtime because you work for your lunch at work, then make sure you're timing them around and is good for you and your lifestyle, because you're more likely to take them. And if you're struggling with this, please go back to the healthcare professional who prescribed it, and they'll be able to help you, because as prescribers, there's no point in us prescribing medication if it's not going to be taken. So we do need to work with our patients to make sure that it fits in for them as well. Please don't miss doses. Even if you feel better, don't stop your course. This is to avoid antimicrobial resistance and any potential relapse, which could lead to treatment escalation, which we don't want. If we can capture you and look after you with pouchitis at a lower intervention, then that's better. So a little bit more about the drugs. So ciprofloxacin. There is a driving warning on this one. It may impair performance of skill tasks, e.g. driving. The effects are enhanced by alcohol, so it's best to avoid alcohol when taking ciprofloxacin. The absorption of ciprofloxacin can also be reduced by oral antacids, calcium, iron, zinc salts, dairy products. So we should have a little break for at least 2 hours before and 4 hours after taking the ciprofloxacin. For ciprofloxacin, it will have this warning on the label when it's dispensed to you, and also in the patient information leaflet that's found inside of the box. So you don't feel you have to remember this, but I just wanted to flag it as something to be cautious of. The next drug is metronidazole. So to avoid alcohol during the course and for 5 days after stopping, because you can have a strong reaction to alcohol when you're on metronidazole. Tinidazole, it's the same family as metronidazole, so there's a possible interaction with alcohol. So any patients who are starting on this, I advise them to avoid alcohol during and for 5 days after as well. Rifaximin, the action of this is another drug just like loperamide, where the main way it targets and improves is in the GI tract itself. So there's very little absorption into the plasma. So I just think drugs are fascinating. So for this one here, it's a great one for our GI patients because we're not having that high level of absorption. So we don't have to worry about it being given orally, and it's a good target. That's why we use it as one of our last line in case patients aren't responding well to ciprofloxacin and metronidazole. Probiotics, I know in the past when I've done these meetings or spoken to patients, or even still now in daily practice, probiotics is a bit of a hot topic. But unfortunately, we no longer have we're no longer able to prescribe via the GP or the hospital. But if it's something that you'd want to try, you can buy from your pharmacies or your local food stores. And this is the one that we used to use a lot in the hospital, the VSL #free. That was the main one we used to use in the hospital. A lot more research is needed, especially into probiotics. So other prescription-only medications that you might find used, amitriptyline, it helps reduce pain, something that neuropathic pain. Ispahula husk, which is a fiber product and can help with diarrhea. Steroids, if you have any inflammation. And with steroids, very similar to antibiotics, take at the same time every day. Finish your course, stick to any reducing regimens that you might be given. If you're having any side effects or any questions, please reach out to whoever prescribed it for you. Nitrofurantoin and colistin. Mesalazine is used a lot to help inflammation of the pouch. GTN and diazepam to help with, so those are used rectally to help with any kind of inflammation you have there. Paracetamol for pain, buscopan for spasms, and then diaurolite or St. Mark's electrolyte mix. Recently, we have had a lot of shortages of diaurolite and the ingredients that we use to make St. Mark's electrolyte mix. So if you're having problems, please get in contact with the Pouch Nurse team, because we have worked on solutions within the hospital for alternative products, so we can share that information. And then you have the cholestyramine and cholesevelam that's used to help diarrhea caused by bile salt malabsorption. So prescription charges, you've been prescribed a prescription-only charges. So as of the 1st of April this year, the prescription charges went up to £9.65p per item. And when it says per item, you could maybe have, as long as it's the same drug, same strength and same form, you will be, let's say you have 4 boxes, you'll still be charged to £9.65 compared to if you only have 1 box dispensed. And this charge is applied at your local and hospital pharmacies. So who's exempt from this charge? If you have a special medical condition and have a valid medical exemption certificate. And these exemption certificates can be your GP or your local pharmacy can help you apply for these exemption certificates. So if you look at the back of the prescription, it says has a valid medical exemption, and here's more information about the valid medical exemption. So you might fall into has permanent fistula, for example, and it gives you examples, or requiring continuous surgical dressings or applications. So if you fall into those, your GP should be able to help you get a medical exemption certificate. But what about other chronic conditions requiring regular medications? So the NHS has a prepayment card, or the prescription prepayment certificate, the PPC, you might hear it called as well. These are available from community pharmacies, GP surgeries. They're available online as well if you just type in prescription prepayment certificates. And then from the online links, you'll be able to call in via phone, or if you can get the numbers from your community pharmacies or GP surgery. So 12 months of the PPC, you can pay that by direct debit, or you can pay, you can pay that up front, or you can pay by direct debit if you want to. So is it suitable for you, these PPCs? I think here's a bit of information I found, that if you have the 3-month certificate, is suitable if you have 4 or more items in this 3 months, and the charge is £31.25p. If you have a 12-month prepaid certificate, it's 12 items or more per year will make it acceptable. Will make it cost efficient for you, because it's £111. Personally, I have asthma, and I have to get an inhaler every 3 months. So for me, when I looked into this for my own personal use, I didn't think it would work out, because actually I don't have this. I don't use it enough to make it beneficial for me. But it's just something that's for personal preference. But I just wanted to highlight it in case you weren't aware of this, just so something you can consider to help make your prescriptions a bit cheaper if you are paying for your prescriptions yourself. Something that's new for April 2023, and there are females amongst us in the audience. So it's one if you have HRT prescriptions, and it's particularly for HRT prescription prepayment certificate. So it's for 12 months, and it comes in at £19.30, and it's viable for you, or will save you money if you have more than 2 HRT medications in 12 months. So something for just something for you to know about, that this is something that was brought in newly this year. So now we'll look at over-the-counter medications. You do not need a prescription for this. They're broken down into two forms. You have pharmacy-only medications, or they're called P drugs, and they must be sold under the supervision of a pharmacist in the community. And then you have general sales list medications, and no pharmacist supervision needed. But however, sometimes the pack size tends to be restricted. So a drug that falls into all of these categories is loperamide. So in larger quantities, it's a prescription-only medication. If you have certain forms, it's a pharmacy-only medication. And if you have very small pack sizes, it can be sold as a general sales list medication. So that's a good example of how one drug, depending on its formulation and its pack size, can fall under all three categories of drugs that we supply here in the UK. So I just wanted to show you this. This is from 2020. So it's a little bit dated, but because of lockdown, I haven't been able to pull off new data. So it looks at the over-the-counter or OTC medication sales. And I just wanted to highlight this to you because this was pulled from the general population, and everybody on this call here is from the general population. So just things for you to be cautious of when you are buying over-the-counter medications. The top one was for pain relief. So think about topical and oral. What are you buying? So for instance, one thing that we say to be cautious of is NSAIDs or non-steroidal anti-inflammatory drugs, because these are things like ibuprofen and diclofenac, because they can cause ulceration in the pouch and potential bleeding. So when you're buying your pain relief, just make sure nothing you're buying contains ibuprofen or diclofenac, either in the oral or the topical form, just to be safe. The next ones were vitamins, minerals, and anti-tiredness drugs. So because we know that our patients not only have reduced absorption of medications, but also of nutrition as well. If you are thinking that you need to top up and to purchase this, we need to have your iron levels been taken, and also just think now if you're reaching more towards buying vitamins and trace elements and you're feeling tired, do we need to come back into the hospital and have a review? Cough, colds, and sore throat therapies. These come like for liquids and decongestants as well. So when we're thinking about that, we need to think to ourselves, do you have any form of infection? Are you feeling a little bit tired? Have you got, especially for sore throats, we always tell patients just to be cautious if they have a sore throat of unknown cause and they're not feeling too well. So just think, actually, are you getting a little bit poorly? You need to see somebody, whether it be your GP or somebody in the hospital, instead of treating it over the counter. Or if you are treating it over the counter, please just be a little bit more cautious and careful in monitoring yourself. And if you're not getting better, then you must go and see your GP or inform the team at your hospital team. So GI drugs, so indigestion remedies, laxatives, and diarrhea treatments. If you're having to reach and buy any of these over the counter, because your symptoms are becoming worse, then you must come and see your GP or come and get in contact with your team in the hospital. So skin reactions, infections, dry conditions. There's an underlying reason why you've had your pouch. So some of those reasons can cause skin, also cause skin problems, just because the nature of the underlying disease. So if these are getting worse, or you feel that you're having to buy something over the counter, just stop and think, could this be related back to my underlying condition, and do I need to actually see my GP, or again be seen by the team here in the hospital? So it just got me thinking about actually people buying drugs over the counter to help treat the signs and symptoms that they may have. But then how do we think about this for our patients with pouches, just to make you think, actually, if I am reaching to buy any of these, do I need to be seen by a GP? Do I need to be seen by the hospital? Do I need to keep a closer eye on myself? So if anything's not working, I can then come and be seen sooner rather than later. And again, it's my plea, please avoid NSAIDs, such as ibuprofen and diclofenac, again, because of that ulceration and potential bleeding of the pouch. So pregnancy and breastfeeding, you have to be cautious. You need to weigh up the benefits and the potential risks. The benefits of giving drugs, but then the potential for the mum and for the pregnancy sometimes as well. And then there's risks also to particularly the to the fetus. So it's always really important that if you are planning on getting pregnant, are pregnant, or are currently breastfeeding, that you ask your medical team. We have lots of resources in the hospital that we can go through. We can look at what's going on with you medically. We can look at the condition. We can look at the drugs and then weigh up the benefits versus risk. There's no perfect answer, and everything needs to be done on an individual basis in order to assess that risk and make sure that we've come up with the best plan for you and work with you as well as the patient to make sure that you feel comfortable with this plan too. So the safety data on pregnancy and breastfeeding, there's no clinical trials because this is a massive ethical issue as we can't do clinical trials on pregnant women. So most of the data comes from if a woman has been exposed to a drug without knowing that they were pregnant, then that data is reported and collected and put into databases. We do have some animal data or animal model data, but it's hard to apply to human models, and many factors may be taken into consideration. So we also use general pharmacology principles. So this is how the drug works on the body to try to predict how it might potentially affect pregnancy or breastfeeding. We also monitor the condition progression or prognosis to see actually what do we need to do to intervene. And healthcare professionals will work with you to try help you make the right choice or to guide that choice if needed. But it's something that we know that it's a very special time, and we don't want to cause any additional distress or don't want to force anybody to do anything that they don't want to do. So it is handled very sensitively. We have had a number of women within our service who have gone through and had healthy and delivered healthy babies, and mum and babies are doing well. And a lot of these women, they told us before they even got pregnant that they wanted to get pregnant, and right from the start, before they even got pregnant, we started to make interventions in their medication and give them the correct kind of supplementation and support to make sure that the pregnancy was the safest we could possibly make it right from conception. So where to find information? There's a lot of information out there, especially if you're internet savvy. So we've got patient information leaflets. They're great. They're from the manufacturers and they're found inside the medication box. Every medication that you have dispensed should have a patient information leaflet. You have your doctors, nurses, and pharmacists. And if you have medication dispensed from our hospital here, you might have noticed an information leaflet inside there giving details of our medicines information department. Now, this is a team of trained pharmacists whose sole job it is to provide information about drugs to healthcare professionals and to patients. We're really lucky at St. Mark's because we are attached to London North West Trust, and they actually have a regional medicines information department led by a wonderful pharmacist. And so they do some really good quality work with our patients. So really appreciate them. You have online sites, but just be cautious of the information that you're looking at. So if you have a query, type in NHS after the query and try to use an NHS verified source, because that's going to give you correct and accurate information. So that's the only thing I'd say. You have charities that support patients, such as the Red Pouch and many others, Pint, Crohn's and Colitis UK, and they have a wealth of information, and the information is verified and checked and is safe, which is the most important thing. Thank you for listening, and if you have any questions, I'm happy to take them, and I'll stop sharing my screen.
You're muted.
Can you hear me? Yeah, brilliant. Thank you very much indeed, Uchu. That was a fabulous blast through pharmacy for Pouchitis. Brilliant. So there's some great questions here. I hope you don't mind getting a few questions.
Yeah, no, definitely.
Great. Okay, super. All right. So let's start with basics. There was a simple clarification requested. If we don't have guts, if we don't have large intestines, and yet the drug is absorbed through the large intestine, do you advocate an alternative route for the drug to be administered for it to be useful, absorbed and useful for Pouchitis? And is it therefore, I think you mentioned that in your slide, is it therefore completely worthless to take a drug that's absorbed in the large intestine when we don't have a large intestine?
Yes, so this is why I mentioned it, because so as you go, so different drugs are absorbed in different areas of your bowel,
Yeah.
and that could be for two reasons. One, because of the way that the drug's chemical structure actually is, so the drug itself, so its physical state, or it could be the way that a manufacturer has formulated the drug. So taken that chemical structure and put it into a solid form. So it could be a tablet, it could be a capsule. So then it releases in the colon. So you could, if you have a drug that has in itself only can be absorbed from the colon, then that's not going to work. But if you have a drug that's been formulated to release and be absorbed in the colon, then there could be a form of that drug that could be given to so it can be absorbed higher up. However, healthcare professionals need to know or have an understanding of your anatomy to know that these drugs shouldn't be prescribed for you. So this is why in one of the slides I said it's important to have a basic understanding of your anatomy. And even if you don't, that's absolutely fine, because I know it's a lot of information sometimes for people to absorb and take in themselves. But you can just highlight it to any healthcare professional that you're dealing with that I don't have a full bowel, so I just need to be cautious with the medication that I'm taking, because it might not always all be absorbed. And then they can go from there, do some further digging, make some calls, and then come up with the correct plan for you.
I think that makes eminent sense, and I think we'd all agree that sounds straightforward. The problem is a lot of Pouchitis, like a lot of the general population, won't be aware of drug absorption characteristics. They won't be aware of whether a particular drug is absorbed in a particular place in the body, let alone in a altered plumbing body like a Pouchy body. I think that's quite a challenge. But I hear what you're saying, and I understand that. And we get a lot of commentary about having to frustration with particularly GPs not understanding the healthcare condition, which to a degree is understandable. They can't know everything. But when you're asking people who have no knowledge of pharmacy, drug pharmacy, to go in and actually help their GPs and prescribers to understand altered absorption patterns, I think that's quite a leap for a lot of people.
You don't. Well, I think I'm not asking you to go in and help them. I'm just saying give them a heads up. Just tell them I do not have a full bowel anatomy.
Yeah.
You need to be careful with what you prescribe me.
Yeah.
And then we have ways of communicating within the NHS, so that information can be readily available to GPs, to community pharmacies, because we all can access patient records and then have a look to see what's going on. And we do have medicines information departments that they can call and ask for a little bit more help and support. And then also as well, they have the contact details if you're a St. Mark's patient or your centre, that'll be able to give them a little bit more help and advice. So I'm not asking everybody to go away and educate other healthcare professionals on this. I'm just saying, just give them a heads up and just tell them, that I don't have a normal anatomy. And I just need to be careful. I've been told I just need to be careful of the kind of drugs that are prescribed for me.
Okay, that's great. Thank you. Some fine detailed ones. Capsules or tablets for Paramide. Is there a difference in the absorption profile that's relevant for Pouchitis, capsules or tablets?
So we'll always start with capsules in St. Mark's. And And if we are finding that it's giving the desired effect, then yes, great, carry on for you. If it's not, we can move to, I think, St. Mark's. We go to the next line, which are the loperamide melts, and we'll try those. And if that's giving the desired effect, great. But we tend not to use the liquids, or we can't use the liquid anymore because that's now not available. In the centers, they might go from capsules, tablets, and then to the melts themselves. So it all depends on, as in my talk, I said we monitor the clinical outcome or the pharmaceutical response. So we'll try it, and if we're getting the right pharmaceutical response for you, then that's where we'll hold you. So it's not a one size fits all, because some patients, and the vast majority of patients, are absolutely fine on capsules, but then there are some patients that we need to move them on or escalate them to either a tablet or a melt.
Okay, so if people are buying their loperamide over the counter or even GSL, they should look for capsules in preference to tablets. That's the recommendation.
Yeah, but if you're buying them, I don't know, it might be very, yeah, yeah, I don't know how much it would. I think if it's working for you actually, and you're happy to continue buying them over the counter, then that's fine. But if you're, so I'm just aware that we are in a cost of living crisis, and
Yeah.
and if you find, if your GP is willing, then it might be more cost effective to get it on prescription and to either use a prepayment card or ask the GP to prescribe a larger quantity. So you're only paying one prescription charge for a larger amount of the loperamide instead of buying it over the counter or from a pharmacy where you'll have smaller pack sizes. So it's just something to consider. If that's okay for you, then by all means, I'm not saying stop it, because we have to do things that are suitable for ourselves. But if you are struggling with that, then please speak to your GP.
Okay, super. Thank you very much. It's a personal question. I think there's a balance. Personally, I think there's a balance between allowing your body to adapt to the new plumbing and providing artificial support through the use of medication. Do you see any contradiction in the two?
So when you have surgery, especially bowel surgery, there's a period of adaptation, depending on the type of bowel surgery you have and the type of bowel surgery you have, how quickly you recover from it, and the patient themselves. It might take your bowel longer or shorter period of time to adapt. So it's a well-known fact that you do have a period of adaptation, and during that period of adaptation, to get you through, and then when your period of adaptation comes to an end or finishes, you might still continue to need that additional support. But it's all very personal. And if you need that additional support, I would say don't feel bad or don't feel any stigma in having to take that additional support to make your life and your quality of life better for you.
Have we got more? Okay, so I think that's loperamide done. But please, if anyone has any more questions on loperamide. Oh, there's just a comment coming from Fiona. Does a capsule dissolve in the stomach so the medication can be released, or could it be dissolved later?
So the way that oral dosing works is, in order for a drug to be absorbed from the gut or be free from the tablets or the capsules to target receptors in the bowel, you first need to form a solution. So with tablets and capsules, the first step of forming that solution happens in the stomach. So the tablet or the capsule first has to disintegrate, and then with the contents of the fluid in your stomach and any water you've ingested at the time of taking the tablet or the capsule. That will start help to form the solution. And then there's several chemical reactions that happen depending on the drug, but I will not bore you with all of that. And from there, the drug is absorbed. So yes, the disintegration, which is the first part of that drug forming a solution, does happen in the stomach. However, if you have things like melts, that disintegration and forming of a solution starts in the mouth. So that's why those ones are a little bit better to help with the drug targeting receptors, whether it be in the bowel or to be absorbed from the GI tract, because that disintegration and solution formulation starts sooner. So when it hits the stomach, it's already in form of a solution. Does that make sense?
It does. I mean, is that acid? It doesn't get degraded in the stomach, does it?
No, so all of the drugs that are formulated to take via the oral route will not be destroyed in an acidic environment.
Okay.
However, some of you might have heard, so like insulin's a good example. Insulin does not come in an oral form. And that's because it will be disintegrated by the acid in the stomach. So there's some drugs that will never come in an oral form, because one of the reasons being that it might be altered, damaged, or its functionality reduced by the acidic environment. So if you, it's fascinating. I could do a whole another half an hour talk on it, but I will not bore you all. But it's just, yeah, so any drug that's, so be reassured, anything you're taking in the oral formulation is fine in an acidic environment.
Yeah. I mean, the drugs go from pH 2.2 in the stomach to pH 10 point something in the duodenum, don't they? It's quite an assault course for a drug.
Yeah, and again, not to go through, I don't want to blast you with all of the nitty gritty, but that for a lot of drugs, they need that conversion from to help them. How best to describe it? So some drugs, when they enter an acidic environment, it changes them to allow them to be more easily formed. Need that alkaline environment to help them make that change or transformation, to help them to be more easily absorbed. So it's actually quite fascinating how chemists and scientists have utilized the natural pHs that we find in our bodies to allow us to form or formulate medications that will help us. So it's just really fascinating stuff.
Right. Let me ask you a very specific question. Michelle has asked about blood thinners and how they affect pouch function and pouch health. Any comments?
So it depends on what blood thinners that you're on. You have antiplatelets, anticoagulants. So those are the two main ones that you'll see. You can have them in the oral formulation, or you can have them in a subcut formulation. So there's always an underlying condition as to the reason why you've been given a blood thinner, whether it be an anticoagulant or an antiplatelet. With your pouch, again, I would just tell whoever's prescribing that or started it for you that you do have an altered GI anatomy, just so they're aware, just to make sure that you're going to get the right absorption. Because for some of them you can monitor. You might have heard of INR, when you can monitor for things like warfarin, but some of them you can't monitor, so people just need to be a little bit more more vigilant when prescribing, or prescribe you something that they know that they can monitor. So in terms of the impact onto the pouch, say that I am not specialized in that, so I don't know if I can give you the correct answers, or that your whoever's prescribing it has reviewed that and has spoken to your surgeon, because I think everybody's very individual, and depends on the way your pouch has been formed. If your surgeon feels that you could have those complications, if you've had any pouchitis in the past, if you've had any complications with it. So I don't want to say something and worry somebody on the call. whereas I think it's all very individual, and the more and more I practice, the more I realise that care isn't standard, especially in St. Mark's. It's very individual, it's very personalised as well.
Yeah, excellent. Thank you very much. Just missed one on loperamide, coming back to loperamide from David Skinner. So he talks about severe dehydration with loperamide. I don't know if that's the thing. And he's asking if there is anything out there, an alternative to loperamide that doesn't have a dehydrating effect.
Um,
You mentioned codeine.
So interesting. I wonder whether I've actually never heard of codeine. It's a hydration.
What?
Maybe it's your running, David. You know, if you run 10
Or
miles every
My hands dry out.
but I wonder whether it could be. Again, I can't comment because I don't know your full situation.
yeah.
But I don't know whether it could be. Maybe if you're taking the loperamide, the reason why the loose stool motions, could that be causing you dehydration? I'm not sure. It's not listed. I've just double checked in the BNF, which is the British National Formulary, and it's not listed as a known side effect. I'm just quickly checking in the summary product characteristics, which is the manufacturer's details, to see if dehydration is listed as one of the common side effects. So I would maybe suggest that you probably get this reviewed by your GP or the team here in St. Mark's, if you're looked after by St. Mark's or whoever your local team is, just to we can easily do a urine sample, and we can look at the content of the sodium in your urine, and that will tell us if you're dehydrated or not. And they may be able to support you with maybe be able to support you with ways to keep yourself hydrated, especially if you're a runner as well. So I'd maybe next time you're in, ask them to just have a look at this, look to check you for dehydration, and whoever you see it say that in St. Mark's will know exactly what to do.
Okay, thank you. Actually, we had another comment from Grant, similar comment, and he's asking if the dehydration might actually be due to lack of absorption of fluid in the intestines rather than presumably loperamide.
Yeah.
Okay, let's move track a little bit. There's a question from Peter on SIBO. We're going to come on to vitamin B12 in a minute, so don't worry, everybody, if you've asked a vitamin B12 question. That's definitely a hot topic at the moment for Pouchitis. SIBO. Does SIBO have an influence on meds absorption in the gut, in the remaining gut?
So with SIBO, you get a lot of distension and bloatedness. I don't know of any clinical trials or studies that have been done to look at the effects of drug absorption in or reduced or altered drug absorption in patients with SIBO. I'm trying to think practically and thinking back onto basic principles.
Yeah.
And would it have effect? But the only thing I can think of is that some manufacturers have, just as I was telling you, chemical drugs are formulated to take advantage of the different pHs that you find in your bowel. Some drug companies take advantage of the different bacteria found in different sections of your bowel to help the drugs be relieved, cleaved, or to be released.
Yeah.
So if you have a drug that is formulated to be supported by the gut flora in its release, then SIBO would affect those particular drugs. But for drugs that are not designed in that way, I don't know of any studies that have looked into that.
Okay. Peter asked the question, Peter, is it something specific that you wanted to address?
Yeah, no, the reason is I take heart medications, and we're in a debate with the gastroenterologist so whether see, and all the signs are that yes, I have. So obviously, with the drugs that I take, we've got the whole box of them here. We've dapagliflozin, we've got prednisolone, range of them, and obviously, if I'm taking them and they're not being as effective as this, affecting my hopeful recovery from my so it's a question I basically need to put somewhere. If you don't know, then somebody else hopefully will know.
So with that, it could be, it might not be the SIBO, it could be other factors. So in order to
More sort
check,
of small intestine syndrome.
yeah. So what we recently I put together some guidance, some national guidance on how to predict whether medications would be absorbed, but this was looking around patients with short bowel, and there's certain characteristics of drugs that you can look at to determine whether they're more friendly for St. Mark's patients or patients with GI anatomy alterations. And what we could do is, are you based at St. Mark's?
Unfortunately not, but I am actually due to see somebody there in September. So
yeah, when if you've got a piece of paper with you, if you can just remember to ask them to contact, if they just drop me an email when you're here in September, what I can do is I can take the full details of all of your drugs, and then I can take the full details of your anatomy and go back and have a look at any changes in your physiology. And then what we can do is we can look at that and compare it to the criteria, and also we can run that through our medicines information department so we can get some up-to-date information, and then so at least we can give that back to your clinicians who can maybe work or pass that on to your GP or cardiologist, just to make sure that we're trying to give you the best possible care, and then we can work that way. So I couldn't tell you if it's the SIBO or if it's other factors. I'd have to take a deep dive and look into it, but I'm happy to do that. But you've got my name now, so whoever you speak to in St. Mark's, just say that we had this conversation and just ask them to drop me an email, and I'll keep my eyes peeled.
That's fantastic. Thank you very much.
My
Super.
pleasure.
Thank you, Uchu. All right, let's talk about vitamin B12. So vitamin B12, as you probably know, some consternation within the pouch community about total vitamin B12 measurements by GPs as opposed to available vitamin B12, and about the fact that some pouchy patients may be actually have a very low available vitamin B12 when the assay demonstrates total vitamin B12 within the normal range. So that's one issue. And the other issue is then how best to treat if they've got low vitamin B12, given that we don't absorb it because we've not got large intestines.
So it's a 1 milligram intramuscular dose every 1 to 3 months. It's not, GPs can prescribe it, and GP practice nurses are trained to administer.
Okay, that's really, I mean, I guess the question's more about availability of that prescription if the total vitamin B12 is within normal range. And my understanding is that the GP's hands are tied if the vitamin B12 is within normal range. There's no clinical justification for giving any supplementary medicine.
So I can't comment because I don't know all of the different assays that are used by everybody's GP practices. So you're right. Every GP will have guidance from the commissioners that look after them, and will tell them what they can and can't do. So, but also as well, we are individuals, and I think our cohort of patients is very very individualized compared to other maybe cohorts of patients. So but then your GP will also be looking at other parameters. So one of the things that flags if you have very low vitamin B12 is that you'll be anemic. And there's a certain type of anemia that you'll see with patients with low vitamin B12. So if you have a picture of a vitamin B12 that's saying that it's in the normal range because the assay is felt or deemed to be not reporting accurately, but then you have somebody with that type of anemia that's very classic and can be seen to have low vitamin B12, then I suppose it's clinical judgment that comes into play. And a lot of GPs will have access to hematologists and such forth, so they'll be able to give further directions. So I do think on the whole it's I hope GPs are looking at the whole clinical picture and assessing patients that way instead of just looking at one individual component. So I hope that answers the question, that there are different things and different parameters that healthcare professionals can look at to try to make that clinical judgment and that clinical call.
Yeah, I mean, Peter, I know you've got your hand up. I'm just going to carry on this question just for a moment and then come to you. But a question from Michelle Putnick with regard to vitamin B12 melts. I don't know whether they're prescription or whether they're OTC or what the availability is. But the question is, are they more effective for pouch patients?
To tell you the truth, I've actually never heard of vitamin B12 melts. Maybe that could just be an oversight on my part, so forgive me. So I can't comment, to tell you the truth, but we do tend to use the IM intramuscular injection. And that tends to be the standard therapy that's used up and down the country.
Well, we've got Fiona showing us Boost. Is that, Fiona, do you know if that's available on prescription or is it over the counter? Do you purchase it?
I purchased it after speaking to St. Mark's. It's a liquid, a spray that you put in your mouth and it's absorbed through your cheek.
Vitamin B12?
Yeah.
I
can't show it. So,
and who did you speak to for that one? Was it a dietitian, nurse?
I think it was Raleigh, but she obviously doesn't know much about me, so it was just email correspondence.
Okay.
And she suggested, because I can't get it from my GP, that I tried this to see if it made any difference to increase the argument for fatigue, maybe, and getting B12 as it shows up as normal on my blood.
I'm going to drop her an email just to check where she got her clinical evidence for that one, because I personally wouldn't have recommended it.
Right, Pierre. Peter, you're up.
All right, sorry. Yeah, the NICE guidelines are currently under review. Some period which I think goes on to the end of August. We're very interested in it, including the B12 Society and a lot of other people worth in. It's a very, very hot at the moment, particularly with COVID, the big factor in B12 deficiency, or the other way around, come out in the inquiry. Certainly from my personal experience, B12 in my problems and also my recovery. But basically, is the testing, as most GPs probably won't admit, but it is that is not what it should be. The standard tests, as Dave really get down to the clinical thing. So really, when my B12 injection started, and the general consensus from that continue on until the symptoms resolve themselves. So somebody that would be where there is a definite problem with the bowel and B12 is absorbed at the terminal.
What's your question, Peter? What's your question?
Well, yeah, basically it's to say that you can't trust the system because the system is letting people down in the system as we speak. So, but in the meantime, you know, there, a lot of the GPs, from anecdotal evidence on the website, are not paying attention to the guidelines. And that is the problem. People are not getting their.
I think no, that's a point you made very clearly before. This is the question for Uchu would be, I mean, Uchu can't influence what GPs do and don't do.
Doing in the hospital, and what she stated there, obviously has to be a loading dose. There is a you know, 1 to 3 months. I mean, I have a one IBGP. I know for a fact that that was not adequate, but I mean, circumstances, it has to be on the symptoms. Somebody that has like neurological symptoms, 12 or anemia, then you need more frequent B12, and it's
if indeed
once a
your
month.
symptoms are caused by vitamin B12 deficiency.
Well, they are. Let's be honest about it.
Well,
We've
yeah,
proved that.
Well, that's difficult. That's difficult, isn't
You
it?
know, and I mean,
Look,
I'm having this argument with the GPs. And
let me ask the question that you popped into the chat, which I thought was more relevant for Uchu. Just giving vitamin B12, aren't there cofactors that are also required, Uchu? And is it enough just to give vitamin B12 high intramuscular, or do you have to also give the cofactors?
So in our trust guidelines, we would just give the vitamin. It depends on what's caused.
Yeah.
So if there are some patient cohorts or patients who do need folic acid and vitamin B12.
Folic acid was what I was thinking of. Yeah.
Yeah. But again, it's very individualized. Your folate, we can measure folate.
Yeah.
For in patient groups. So if your folate and your vitamin B12 is low, we can top it up. There are some patient cohorts simply because of their disease, we know that they will need additional folate or and vitamin B12. So that's just automatically given.
Yeah.
So everything is heavily protocolized, and the hospital protocols or local GP protocols are derived from NICE protocols. So protocols are formed, and these NICE protocols are written by people who are very specialized in the area, working in hospitals and GP surgeries, and will work with NICE to write these protocols, and everybody else will adopt them or tailor them to suit their local areas or local nuances. Yeah. So that's how we go about writing it. So in our hospital, if we were to prescribe vitamin B12 for a pouch patient, we'll have a look to see if they fall into any of the cohort, and then pick the right protocol to give or to start.
I mean, those protocols are evidence-based. They're based on evidence, aren't they? They're based on science. Yeah. They're based on solid data. They're not just made up, and they're not budgetary constrained. It's based on evidence-based medicine, isn't it?
Yeah.
Yeah. Okay, let me move you on to something else. Blockage stroke spasm. It's something that pouches get occasionally, hopefully occasionally. Some get more frequently than others, depending on diet, whatever. If someone has a blockage or a spasm, whatever the terminology is, what can be done pharmacologically to help them in their hour of need? Do people with blockages need to go to A&E, which is what some people do? Do they just need to sit it out at home? Or is there an indication when they need to go to A&E? And if they're in A&E, what would the pharmacology be to treat the condition?
It all depends on what's caused that blockage or that spasm.
Yeah.
there's some things that so I think the first, so if you were at home and you have, and so even going back a step is that hopefully all of you have been given direction by your teams as to what to do. So we call it safety netting. So if you know that something is going, so if you have this, hopefully your team is giving you clear direction on what you should do and how you should approach that, whether it be to go straight to A&E, go to your GP, sit and wait it out, or what some people have done is prescribe what we call rescue medication. So things that they have just in their cupboard. So if XYZ happens, they know to take it and then either call the GP or go to the hospital. So we call that safety netting, where we try to make sure our patient is as safe as possible before we let them go home. Depending if you did go to A&E, they would first determine what's happened, how it's happened, and what's caused it. And depending on all of that is depending on what medication they would give, because there's some medication that you need to avoid, but all be determined after the results of any tests that they need to do in A&E.
Okay, so there are drugs that can help with blockage, stroke, spasms.
But it all depends on what's caused it, how bad it is it partial, is it fully, what's the underlying conditions, the quality of the pouch. So there's a lot of things to take into consideration, but hopefully you have been provided with some safety nets by your team, and also as well, if you go to A&E, those tests and investigations will be done before prescribing is given. But I think that first things first, and it's going to be potentially quite painful. So they'll just try to make you feel comfortable as possible, and then while they're doing the investigation.
Yeah, excellent. Thank you very much. Can I ask about the future? Obviously, there's drugs being developed all the time. We've got one question about an IMAP, which I'm going to come to in a minute. I'm conscious of time. I'm conscious it's nearly 9 o'clock. But from your perspective, in the future, is there anything up and coming on the rails that's a wonder drug that will make pouches fabulously healthy or good looking, or both?
Well, if there's a drug to make people good looking, I will be in the front of the queue to take that. As I think it would be out of stock immediately as soon as it's approved by NICE. But in terms of pouch, I am not aware of anything that's on the horizon at the moment. And we, as part of our roles as hospital pharmacists, we have to do horizon scanning. So it's to look out for new drugs that are coming out. There was one question, a comment that was made, was that somebody said that they're surprised about ibuprofen, but they knew about NSAIDs. I just wanted to let you know that ibuprofen is an NSAID. So just be cautious of that.
So we're almost at the end. It's brilliant. But Susan just asked a question about a specific drug. Now, obviously, Uchu may not know your particular circumstances, Susan, so just be conscious of that. But Susan's having an injection of denosumab, which is one of the new biologics. Is there anything that she and the doctors at her local hospital should be aware of as a pouchie?
So if you're, let me just. I'm pretty sure it's a subcut injection. Forgive me.
You don't have to apologise. Honestly, you're obviously researching stuff while you're talking, which is a real skill. So you don't need.
Let me just double check this, because I think I know what it is and how it's used, but we don't use it in our clinical area. And when I was a junior pharmacist, it wasn't available. So some of the new things that are in other areas, I'm not. It's so it is a.
I mean, there's a whole family of IMABs, aren't there, or UMABs?
Yeah, so different ones are used in different areas. So we have a lot that we use within IBD, within IF, so intestinal failure and inflammatory bowel disease. And it's the same, they're monoclonal antibodies. Because they are, you know how we spoke about the acidic and the alkaline environment in your stomach? So drugs like the MABs, they are based on living cells and they replicate living cells. So you'd have a drug like aspirin, that's just a simple chemical structure that could survive those fluctuations in pHs. Whereas drugs like the MABs, they're based on living structures. So if they were to be put into that fluctuation, they'll denature. So you wouldn't have them orally, you'd have them in the subcut. So in terms, or you'd have them given via IV. I'm just trying to double check what route this one goes by. So in that case, you don't have to worry about absorption because you're bypassing the bowel and you're going directly into that systemic circulation. So you don't need to, so it's given 60 milligrams as a single subcut injection every 6 months. So so you don't need to worry about absorption issues in that respect because you're bypassing the bowel. And one of the things with monoclonal antibodies is that your team will keep an eye on you just to make sure that you're getting that response. And I'm just looking up something else about it quickly.
So the route of administration is perfectly fine for Pouchitis.
Yeah, and the reason why you've been given it, because again, I don't want to invade your privacy too much, but just having a quick read about it now, your team will be able to easily see if it's working for you, because the reason why they're giving it to you can be monitored and can be looked at and can be reviewed. So don't worry about it too much. One, you're not going to get any problems with absorption, and two, your team can monitor to see if you're getting the correct pharmaceutical response.
Good, excellent, thank you. Okay, methotrexate and steroids in combination in Pouchitis. Is there anything to watch out for there?
So
sorry to spring it on you.
No, I'm just thinking. So when do we use methotrexate and steroids in combination?
Rheumatoid arthritis.
Yeah, I'm just thinking. So steroids tend to be it depends on. So there's a lot of. So I'm just thinking of all of the different circumstances and situations that you'd use the combination of the two, and the different kinds of doses that you'd use, and how if you'd be escalating one, de-escalating one. So it's a hard question to answer because there's so many nuances to that combination of therapies, and there's so many different reasons. So there's different combinations, there's different reasons why you would use it, and each would give you a slightly different outcome. I think your team, they just need to know that you have the pouch.
Yeah.
Because these drugs are initiated in hospital and continued by hospital, so they won't be prescribed by the GP, especially methotrexate.
Yeah.
So it'll be by highly specialized people, and they will understand what a pouch is. They'll understand. So as long as you just tell them I have a pouch, they'll be able to take it from there.
Yeah.
And because they're in secondary care, so hospital settings, they'll be able to reach out to your team and find out a little bit more if they're not sure.
Brilliant. I think that's it. Anyone wave at me if...
Yes, me.
Yeah, okay. Come on then.
What can I take? If I can't take ibuprofen, I mean, I'm a runner and I get sore muscles now and again. What's the alternative that I can take?
Paracetamol. Does that work for you?
Paracetamol, okay.
Take a swim.
Contrary to what you said in your very interesting talk, I really enjoyed taking oral Imodium solution. Is there any chance that's going to come back onto the market?
Unfortunately not. The manufacturers have discontinued it in the UK. And I think now some of our European colleagues are struggling to get hold of it as well.
Okay.
So I'm very sorry about that.
Okay. Fiona.
I just wanted to be sure that Uchu knew that I have checked my correspondence with St. Mark's and I didn't get the information about the B12 spray from Raleigh. I got it from my own nurse at our local hospital, so you don't need to email her.
Okay, brilliant. Because she's normally quite good actually, and she'll run recommendations by me. Yeah.
And she
Okay,
was quite
perfect.
clear that she didn't know anything about me, so no, it doesn't come from her.
Okay,
thank you.
brilliant.
Good to know.
Sorry
Thank
for
Thank
that.
you. No, don't worry, don't worry.
David, can I just ask a question?
Yeah, sure.
Just a quickie. Uchu, when are Pouchitis going to get free prescriptions?
So this was, I know that there was work being done. I think it was actually maybe yourself, Chris, who
Yes, it was me. Yeah.
Yeah, it was before the pandemic. I think I did a face-to-face meeting with yourselves.
Yeah.
And then it was spoken about
I
quite
did a
detailed
mini
there.
campaign about it.
Yeah, and I remember to support your campaign that year. I went to we have a pharmacy conference, a big pharmacy conference each year, and a pharmacist I used to work very closely with, I bumped into him and I was asking what does he do now? And interestingly, back then he worked for the Department of Health, and I did put your case forward to him, and I explained, this is the situation. There's actually quite a lot of medication involved, and he did say that he'd take it forward, and I know that you guys were doing a campaign, so I haven't caught up with where we are with that and what's going on and
Didn't a
what's
government
happened.
body meet? Sorry to
No,
interrupt.
please, no, carry on.
Didn't a government body meet the NHS or an NHS body at one stage about 2 years ago?
I think they did.
Yeah.
I think they did, and I tell you the truth, I'm just very outdated as to where we are with things and what's happened.
What do you suggest we do?
Write to your local. You might have done this already, but have you written to the local MPs?
Local MPs have been involved at one stage. Yes, I haven't recently. No.
I think pick it up with the local MPs.
Yeah.
That'd be my first port of call to say that.
Yeah.
I would maybe write from the organisation.
Yes.
And do you know what? Be bold. Write to the Department of Health themselves directly.
Okay. Very good. Good advice.
There's other charities that you might want to combine with that have maybe a bit more resource or so it could be. I would maybe reach out to Crohn's and Colitis UK.
Yes, absolutely. Yeah.
And then another one would be Pint, that represent all intestinal failure patients.
Okay.
So
Pint.
Pints. So it's spelled the same way as you spell a pint of milk.
Okay.
Sorry, it's a double N, a pint, but with a double N.
Oh, okay. Yeah.
So I know the chairs are both very active.
Yes.
I'll try to combine and see if together you could do something.
Yes. Okay. Well, thank you very much for being so clear about it all. Thank you.
That's okay.
I'm aware, conscious of time. It's 9 o'clock, just gone 9 o'clock. I think we should let Uchu escape and enjoy the rest of the evening, what's left of it. So first of all, on behalf of everybody who dialed in and everyone who's going to download and look at this, watch this webinar, Uchu, can I extend a profound and profuse thanks for your time and your input and your expertise and your preparation of a very thorough and informative talk, and for hanging around and answering the questions. Some of them were very difficult. So thank you very much.
No, thank you. And yes, it's a very enjoyable part of my job. So thank you for the invitation.
Super. Thanks, everyone.
Right. Take care.
Bye-bye.
Have a nice evening.
Take care. Thank you.
Bye-bye.